I'd like to thank the organisers for the invitation and also for posing the question. I'm afraid that we're definitely now moving towards the overt. The gist I got from earlier discussions was it was a good thing to move towards covert things and early interventions, but I don't think you get much more overt than I'm about to discuss, apart from maybe death. When I looked at the question, I thought, you know, in my brain, I don't have a degree of clarity about this, which surprises me a little bit. And therefore I thought this is actually quite a good topic to go away and get my own brain sorted out and feel a wee bit more clear on whether this is a useful endpoint for studies, for patients. And I'm afraid, now that I've got into it a bit more, I'm still not quite clear about some things, although hopefully I can bring some clarity to my confusion. First off, what should an endpoint be? Well, clearly we want to have something where we either see an improvement in survival, some sort of benefit for the patient, decreased chance of developing something undesirable. And we may use something as an endpoint that is a validated surrogate for what might be a more straightforward endpoint. And how would that relate to acute liver failure? Well, clearly improved survival might be one thing. I think it's an unusual condition because not only can we treat it, but you can get snaffled away and have a liver transplant. So very short-term treatments can sometimes be very beneficial in patients with acute liver failure, where it's apparent that the end game, if it was just to manage them conservatively or medically, would be death. But if you can get them through even a few days to a transplant, that may be a very worthwhile endeavour. I think determining when treatment is futile is also a very useful thing. And certainly in these patients, sometimes that can be quite difficult. And it's beneficial not just to the people looking after the patient, it's very beneficial to relatives to be able to determine at an early stage that things are going nowhere and prepare them accordingly. So I think, again, that's a somewhat specific thing that we could maybe look for. And one area where I think there is a lack of information that would actually be very useful is to look at certain endpoints and relate that to neurological deficit after transplantation or recovery, and be able to relate various treatments to neurological deficits after transplantation or recovery. Now, when we're considering that in the context of intracranial pressure, I think it's important that we have some understanding of the risks, because clearly we know that there are risks in terms of intracranial pressure monitoring, particularly in these patients. And if we can understand those risks, we can have in our head some balance between the risks and the benefits of undertaking the procedure and making the measurement. I think the other thing is looking at other modalities, and there are quite a few around. Several things we need to think about there, not just in terms of validity, but the ability to rapidly detect things. Very often other modalities are actually compared with intracranial pressure, but they don't pick up on the fact that intracranial pressure monitoring is continuous, whereas many other modalities which may come to the fore are discontinuous, which has always been the problem with simply looking at people clinically, that something terrible can go by and you don't pick up on it. So what I thought I'd do first of all, just to try and help me, because basically with intracranial pressure we're looking at a monitor. So I thought there's always the difficulty of instituting some form of monitoring and showing that it's worthwhile. So I thought I'll relate this is just a little aside for a minute or two, to something a bit easier. So I thought, well, maybe blood pressure. In my head, there's some evidence that if you have a mean pressure above 65 in some circumstances, that'll improve outcome. So I thought I'll pull some of that out and see whether I can relate that to ICP. Unfortunately, despite much medlining and Googling, I really struggled to come up with anything very worthwhile in terms of why are we actually measuring your blood pressure at all. And along the way came up with some very recent, which is why I've highlighted the date, but not bizarre, but unusual things that I found unexpected. And I think it's actually quite important, because when you look at papers relating to ICP, some of the things that are highlighted here relate to what you find in other papers, and I'll highlight that over the next couple of slides. So in this paper, there's a survey of what people do to measure your blood pressure. 73% of respondents said that in the critically ill they use non-invasive blood pressure measurements. That's fine. I probably do that in many circumstances. Not when everything is going wrong in ICU, but I certainly use it. In patients and vasopressors, 47% of respondents use non-invasive blood pressure measurements for patient management. That isn't a world that I know at all, and therefore looking at papers that relate to monitors can be unbelievably misleading for the patients that you might be dealing with yourself, and you have to look at it very carefully. One other well-known study, pulse oximetry. This is often quoted, I think, Cochrane database, 4 randomized studies, over 20,000 patients. You can certainly pick up that people get hypoxemic, but it was pretty clear that you didn't actually pick up anything worthwhile in terms of post-operative complications, oximetry group versus control group, no significant differences in anything that might be meaningful. And yet I am pretty sure if I ended up with the judge saying, I'm just quoting the Cochrane database and I didn't bother putting the pulse oximeter on because it's actually been shown of no value whatsoever in these circumstances, I don't think I would get away with it somehow. So again, there's an oddity around monitoring. What about right heart catheterization? I'm sure many of you are familiar with Connors, who kind of binned right heart catheterization in the mid-90s. Up to then, in ICUs, we were swan gans happy. We were putting it into everybody. And what he did was an assessment based on data that had been collected previously, and he adjusted it to try and match patients who had a Swan-Ganz catheter to patients who didn't have a Swan-Ganz catheter but were equally ill, and therefore tried to compare two like with like groups. And it's called propensity scoring. I still can't really quite get my head around some of it. And what he showed was there was an increased mortality and use of resources associated with the PA catheter, but what he also showed, there was no suggestion that it was because as an invasive monitor it was killing people or clinicians were killing people putting it in. It really wasn't due to that. It was due to the whole package somehow, if this is correct, the whole package of care. And again, I think that's one of the things we have to be very wary of looking at monitoring, is that you're not just looking at a monitor, you have to look at what people are doing round about that. And it may be that you can have monitoring that shows a worse outcome in a group or shows no difference, but that doesn't necessarily mean that we should bin the monitor, to my mind. It means we should examine how we're managing the patient. So I think there are still difficulties relating it to the Connors thing, matching patients. One thing that came from that, which again I think can apply to ICP monitoring, is there was a rash of people using poorer techniques to try and measure exactly the same thing, which I could never get my head around. At least measure something different. PA catheters measure pressures when we really want volumes, but instead of that we started putting Dopplers down and doing all sorts of things to try and measure pressures, but just doing it incredibly badly, as though that was going to be a better way forward. It also led to a failure to use PA catheters, which I think is still the case, when sometimes the patient would clearly benefit because it's gone through the usual medical slump of I wouldn't give it to a dead dog now. And I think we need to keep an open mind a little bit and remember that problems relate to the whole patient management. What about ICP then? Well, it's actually fairly easy to show that in fulminant failure, ICP can be related to terrible things happening to you. So these are just two individual patients, terrible clinical things happening here when ICP takes off. So that would seem like this potentially could be quite a good thing to have as an endpoint. Also, which I think is useful, is it's quite easy to show that doing things to people, and in particular doing appropriate things to people that you would expect to have an effect that is desirable, relates to changes in ICP. So this is a study looking at changing sodium using hypertonic saline, and you can relate it quite nicely to a decrease in ICP. Not all the sodium evidence relates quite so well, but it is possible to show that. So again, I think that's also useful. We've got something where we've got a story that seems to make sense, we have an intervention that seems to make sense, it has an effect that we want, and therefore, on that basis, shaping up fairly well, I would have said, as something to use as an endpoint. Likewise, you can look at different sorts of therapy, so giving mannitol, etc., you can show that there is an improvement there. And I'm sure many of you are familiar with this graph from Clemenson, showing that there's a relationship between arterial ammonia and cerebral herniation in patients with acute liver failure. And indeed, that's become the basis of how we manage these patients in ICU, at least in terms of how we might intervene or monitor them. And we've taken that from into clinical practice. So that seems to all hang together and be very positive, I would have said, in terms of using ICP as an endpoint. But it's not all sweetness and light. So if we go back to when the King's group sort of joined the French group and redefined liver failure, so this is really the paper from that study, but it also highlights that those patients most likely to get cerebral edema were already those patients most likely to survive. So it doesn't go just completely hand in hand that cerebral edema equals death. This group does spectacularly worse by and large, as we all know. And yet cerebral edema is much less of an issue. And in point of fact, I'm sure we would all accept that this 35% survival figure now is probably considerably higher in this particular group of patients with medical management. I'm not sure it's 100% as some would say, but it's certainly, I would think, across the piece, a better survival rate. And that may be in the face of having less patients or fewer patients with cerebral edema, but I don't think it's entirely that. So that could complicate things a little bit. Also, if we want to use it as a reason to stop, is that a good endpoint? So this is from quite a long time ago, but it's often quoted, and again, I think the devil to some extent might be in the detail. These are 4 patients who hit fairly spectacular numbers in terms of ICP, low cerebral perfusion pressures, for protracted periods of time, and yet all survived neurologically intact without liver transplantation. There are some things to think about with those 4 patients, in that only 1 patient hit 2 patients hit King's criteria, but to my mind, only 1 patient hit what I would call sort of true blue King's criteria, namely creatinine and PT both through the roof. This patient hit King's criteria, but I'm sure it must have been on the basis of the arterial pH, which I think sometimes can relate to early numbers before resuscitation, etc., and I always think is not just quite so clear cut, in particular when there are 2 patients, and this patient's one of them, who didn't have renal failure post-paracetamol. To my mind, if you haven't got renal failure post-paracetamol, you're not really in the extreme end dying group that I would expect to see in ICU. So there's something just a little bit odd there, and this patient didn't actually hit King's criteria either. That's not to demean it, because I think it's quite well described, but it's to see how do we delve into that and understand it. And the answer is I'm not quite sure around that. But it is slightly odd that not all the features you would expect there are present. That said, in 2 of these patients, they re-drilled the patient because they weren't sure that the pressure was correct. All of them had a good waveform, and they got exactly the same answer. I've stopped doing that. I did it about 4 or 5 times when I thought I had unbelievable answers, and did the other side, and on every occasion I found exactly like they did. It was exactly the same, so that seemed a bit hazardous, I thought. Then I came across this, which I thought absolutely perfect. 2014, outcomes and complications of intracranial pressure monitoring in acute liver failure. I thought, 3 slides from this, job done, easy talk. And what did they find? They found that in acute liver failure, intracranial hypertension was commonly observed in people who were monitored. So at least they seem to be targeting the right people. They found that in acetaminophen, it didn't seem to confer a 21-day benefit, and in non-acetaminophen, it may be associated with a worse outcome. This is from the US Acute Liver Failure Study Group. And again, I think the devil is probably in the detail a bit. So what I thought we'd do is look at our numbers. So we've got numbers over 20 years. So I'll run you just briefly through them, and then we'll relate them to the numbers in the US group and see if we can make a little bit of sense around that. So over 20 years, we've got 1,136 patients who came to critical care in Edinburgh, either high dependency or ICU or adjacent with that. A few of those patients will have come from a long way away and might be relatively well, but the bulk of them are people who very appropriately should be in a critical care environment. Not surprisingly, majority are secondary to paracetamol. And if we look at what we ended up doing in terms of how sick they were, of those who had taken paracetamol, 30% of them, 31%, we ended up putting in an intracranial pressure monitor. 70% we didn't. In those who were non-paracetamol, we put intracranial pressure monitors in about 14%. And in point of fact, nowadays, that would be less, for sure. I think at that time when we started 20 years ago, we weren't bolt happy, but we used it a bit more readily than we do now. We're much more careful about elucidating who is appropriate. So if you said, what is the number now? And I haven't worked it out, but it would be 10% or less in this group. If we look at what happened to them, so this is just taking the paracetamol side, 65 of these patients had a transplant with a mortality of 21%. Not surprisingly, the group who got monitored in ICU but didn't get a liver transplant, probably mostly for compliance, social reasons, etc. Some because they didn't get a liver, the mortality much higher. If you look at those that we didn't put an intracranial pressure monitor in, 9 of them got a transplant with a mortality of 22%. You could superficially look at this and say, doesn't seem to matter whether you put in a bolt or not. The mortality in those groups seems to be exactly the same. And of course you can't conclude that. But in many studies where you look at things, because you end up going into these so many subdivisions, you can conclude all sorts of slightly inappropriate things. And therefore that is fairly meaningless to make that sort of conclusion. If we look at the non-paracetamol group, we can see that 46 patients in this monitored group with a mortality of 30% if you got a transplant, and a huge mortality, perhaps not surprisingly, because these patients usually do fairly badly if you didn't get a transplant. If we didn't monitor you, still a reasonable mortality here, and quite a moderate mortality there. Now if we look at a comparison with the US group, several things to highlight, I think. First off, the number of patients to me seem very small. There are 24 centres in the US group, and this is over 7.5 years versus 20 years, but to me that seems a very small number, which must mean very few patients from each centre contributing to this, which again makes me just concerned about the evenness of how patients are managed across this. If we look at this, we see that looking at monitoring of patients who are post-paracetamol, 20% in these units got an intracranial pressure monitor in a hyperacute situation. And 30% of patients in the non-paracetamol group got intracranial pressure monitoring, which to me seems an enormously high number when you're only putting in 20% to people who have hyperacute liver failure. So there's something strange to me there that it's not a criticism, I just don't understand it. Other features about it, which to me also seem a little bit different certainly, and therefore not comparable, 50% of the patients seem to have slightly verging on the unusual ways of measuring, to me, intracranial pressure. I've never heard of lumbar intracranial pressure monitoring in acute liver failure, but it seems to be quite common in the US acute liver failure study. 50% are probably what you'd expect with Caminos. And I think of these epidurals, I think a significant number were Camino monitors that are designed for intraparenchymal stroke subdural placement, placed epidurally, which seems something I would struggle to do a wee bit, I think. What else can we say? Patients who got intracranial pressure monitors got lots of treatment. I think that's consistent. Any study that's looked at that, if you put the thing in, you start treating them with stuff, but we're not quite sure whether that makes a difference. It makes a difference to the ICP, but does that make a difference subsequently? If we look at this study by Vaccaro, again, essentially the same group, quite an interesting way of looking at things. They looked at ICP monitoring associated with liver transplantation. Some centres put in more monitoring than others, some put it in for transplantation, and what they found was A, more stuff given, and between those groups, 30-day mortality not different. Now that's maybe more valid, because hopefully, it's difficult to know, you need to know what different centres are doing, but if they're taking all comers roughly the same, it means that one group getting transplant and one group not getting one group getting bolts and one group not getting bolts and getting a transplant seem roughly comparable. So, we looked at one other complexity is we looked at what hypothermia does to you, and just to cut a long story short, this is the hypothermic graph during a transplant. People who failed treatment, were cooled, are actually under greater control. So you could argue it's probably safer not to put it in at all. Other things we could do, even this group who are expert at this suggest it's not something that is easily brought into routine practice. And we've had a look, this is my eyeball, with ultrasonography, and it's a bit difficult to see there, but it is a wee bit difficult to see anyway. Although that's me standing up, hanging down, look, you can see it's maybe getting a little bit wider, the optic nerve sheath. And if you follow through somebody who's come in with acute liver failure, you can see that this gets broader. It's a kind of diffuse edge, difficult to measure, and I'm not sure you can relate it to numbers, but it may have some role in terms of who should you put an intracranial pressure monitor in. So what can we say? I think you want to make sure you monitor the correct patients. I think we're better at that. We don't put bolts into people who are less acute. We look at your ammonia level, renal failure, are you hyperacute, etc. I think we've better understanding of coagulation management. Not sure that's translating into less bleeding, and there's probably a 2 to 3% significant risk with it. It's not the be-all and end-all, so I think if you do have an enormously high ICP, you shouldn't just stop. Otherwise you just create a self-fulfilling prophecy and the patient dies again. And what would I say? I think there's a good association with cerebral edema and outcome. It's not perfect, as we've seen. It does respond to a therapy that seems appropriate to me, and we need studies to look at this. And I think ICP monitoring would actually allow us to look meaningfully at that. So I think at least on that basis, it has merit. Thank you.